Welcome to the Sultans of Sales podcast. I'm your host, Jamil Pendleton. Today on the show, we have a wonderful guest, Dr. Ernest Braxton. Dr. Braxton comes to us from Vail, Colorado. Currently a snowstorm, apparently today, which is crazy. It's early November. Dr. Braxton and I know one another from his time in Austin, Texas. He's a neurosurgeon specializing in minimally invasive spine for Vail Summit Orthopedics and Neurosurgery. Dr. Braxton, thank you so much for being on the show. Welcome.
Hey, Jay, it's so good to be here. I've known you a long time, and I'm really excited about what you're doing on social media. And I'm just honored that, I can be one of your guests, and I just want to have a good conversation with you.
Oh my goodness. I am the one that's honored. And I've said this before, but you, sir, are the reason that I even have a job. And, I've been fortunate throughout my career to work with, wonderful orthopedic and neurosurgeons. And it's just spectacular. We get to rub shoulders with some of the smartest people in the world. And it's just wonderful. So thank you. Thank you again for carving out your time. I know it's valuable. So for those that don't know you, where did you get your start? Where did you become a surgeon? Did you always know that was your path? I always like to kind of understand, the origin.
No, I mean, I'm kind of a little bit of a late bloomer. And so I was raised in upstate New York, military family, on an Air Force base. The Air Force base is called Griffith Air Force Base in upstate New York. And a lot of people don't know this about Griffiths, is that it was chosen for its location because it had so much cloud cover over that area that they thought it'd be hard to bomb it. So wow. It's like Castle Grayskull is where I'm from.
That's an amazing reference.
But I always, loved aviation. I loved flying. My dad was in the Air Force. And I thought the best place for me to get an education would be at your United States Air Force Academy. So I show up at the Air Force Academy, aspirations to be, a fighter pilot or some type of pilot. My favorite plane actually was the SR-71, which is a reconnaissance aircraft. And I thought that would be so cool to be able to outrun missiles and get valuable information. And so I wanted to be a pilot, at the Air Force Academy. Okay. And I knew a couple of things. You needed to be smart. You need to be fit. And you needed to, have the chops to fly and get good grades. So I always focused on getting good grades. I was a science major. I majored in chemistry and philosophy. And I mean, medicine was, an interesting, idea, but it's called the Air Force for a reason. It's not the chemistry force, pilots run the Air Force. So, right. Anyways, I was going through the Air Force Academy and everybody's got to go through a lot of physicals. So, I had perfect vision at the time. I'm wearing glasses now, but back when I was like in my 20s, I had 20/15 vision. Nice. And you have to go on what's called a flight screener course. Okay. So the flight screener is just to weed people out. Sure. And they had a new aircraft for our class, which was the Slingsby T3. It was a fully aerobatic, flight screener. And I had some flying experiences in Cessnas and Pipers, and I flew gliders, and that's basically flying straight and level and landing, pretty routine stuff. But this is aerobatic aircraft. I mean, we would do barrel rolls and Cuban 8s and all these different maneuvers, and I would lose it in the aircraft. I would just get sick and just want to be on land, Yes. And after about 6 weeks of just, going down, getting sick, throwing up, I decided, maybe I didn't have the chops to be a pilot. My brother's a pilot. He's also an Air Force Academy graduate, and he got through it. But I just was having they call them physiological events, sure. Every time you throw up, I just got accepted to medical school. I applied to medical school as well, but my goal was, to be a pilot. And I kind of, sat down with a commandant of cadets who's, 1-star general. He ended up becoming a 4-star general, General Lorenz, and sitting me down and saying, hey, can we work through this? I see you want to drop out of the flight screening program. And, I said, I just got into medical school. I'm getting, sick. And he says, like, you got into medical school? you should be a doctor. That's the way to go.
Yeah, he's like, come on.
So
Yeah.
come on, you don't need a pilot. And so he actually signed off on my release to drop out of the course. And I ended up going to the University of Pennsylvania for medical school. And
nice.
I didn't really have much of a clue of what type of doctor or what I wanted to do. I do remember growing up watching this TV show, and this is going to show my age a little bit, called Quincy. And Quincy was like a medical examiner, and he would, do autopsies and find out, he's got kind of the old school CSI, and I thought that would be cool. I want to find out what happened and what is causing the patient to be sick. So I was interested in pathology, surgical pathology. That was my goal.
That's fascinating.
And I got to medical school. Yeah.
You never did. Like, it's unbelievable to hear.
I was a scientist.
Where it started.
Yeah.
Dr. Fan was feeding a baby. You're from the TV show Quincy. It's unbelievable, these careers and these just, game changing for your community. That's just, that's really cool. Please continue.
Right. And so Penn had this really, they called it Curriculum 2000. They had this curriculum that was really patient-centered and patient-oriented. And I just, I had, one of my medical school professors and say, nobody's going to come into you and say, hey, my mitochondria is killing me. They come to you with a problem. They want to fix it, That's right. And I was like, I want to be more at the leading edge of where those problems are and try to fix it, And so that kind of quickly, put me on a surgical path, so I was interested in surgery, to address what is your chief complaint. I ask every patient, tell me, what are you hoping I could do for you?
Right.
Rather than being kind of faceless in the background and the scientist of what, what's causing the problem.
No, that's fascinating. And I think, you want to fix it. You want to actually, use your hands, maybe some of the early things that made you really have that passion for flying, like just controlling things and checking, maybe planning, right. Which is in vogue today, preoperative planning before you take off. So, that's fascinating. Thank you so much for that. Cause I think it helps any of us, even me who knows you, better understand some of the reasons why you do things maybe. And, that's a perfect segue into your practice today. I'd love to, maybe you share that a little bit with the audience about what you're doing today at, at Vail Summit.
So I made a big pivot by moving out to Vail, Colorado. It's a very rural area. And, obviously I trained as a neurosurgeon. My primary interest was, skull base and tumors. And I did a lot of that in the Air Force, but in the Air Force, you have a lot of, folks with back pain,
Right.
And I'd get a big stack of charts, with people with, back pain. And, at first I said, there's nothing I could do for you. I can, maybe get you some, get you boarded out of the military if you can't deploy, but your back pain is incurable. And I really got a lot of mentorship from Texas Back and Jack Ziegler when I was in the Air Force. He kind of got me into anterior surgery, got me into artificial discs. And I thought that, well, there is a cure for back pain. Go ahead.
Well, I'm so glad you mentioned artificial disc because I spent a ton of time at Darnall and Fort Hood, and there were a lot of arthroplasty happening because, as I understood it, the Army, whoever was having the procedure could return to active duty as long as they didn't get a fusion.
Exactly. So by maintaining motion in the spine and not fusing it, we saw improvement or relief of pain in many cases, and people could return to duty. And I was like, This is where I'm supposed to be. I'm supposed to be helping folks, get back to doing what they love, whether that's being a serviceman, flying a fighter aircraft, kicking down a door for a special operator. And then in Vail is an easy pivot to returning to performance, returning to skiing, hiking, biking, golfing. It's almost like a negotiation. I'll say like, well, so when can I ski? Right. I was like, oh, well, how about 8 weeks? They're like 2, 6, 4, done. So we're kind of always pushing the boundaries on when people can get back to doing what they love. And you don't live in Vail unless you want to be active.
That's right. And it's year round. Oh my goodness. We've been there for the winter for skiing, and everyone's like, have you been in the summer? Are you coming back? Like, well, I didn't know about Vail summers. Like, it sounds amazing.
Jay, you come for the winters, you stay for the summers. The summers are the best. They're my favorite time of year. It's just, I put my time in South Texas and in Central Texas, And it gets hot down there, man.
Yes, it
I mean, we don't
does.
have mosquitoes.
Well,
You know, a beautiful day is like, 80 degrees. That's a hot summer day
that's
for
hot.
us. It's just,
Keep
yeah.
talking. I'm gonna get on a plane. I'm gonna come out there. You're gonna have like, I'm gonna be like a stray animal. Once you feed me, you can't get rid of me. I love Colorado.
Yeah.
So okay, I love that. I love the negotiation piece between your patients, because it really is. And it's funny, this podcast, I'm sure you might be aware, it started out as the Sultans of Spine, because that's my love and my background for the last 13 years has been this industry, working with people like yourself. But my wife suggested that not everybody loves spine surgery as much as you and I, Dr. Braxton. And so maybe widen the lens a little bit. You'll get a bigger audience to change it to the Sultans of Sales, which we did before branding it, logo, and all that good stuff. But the reason I bring that up, that sales piece, I consider surgeons the best salesmen around. And I mean that with the highest compliment. Someone's walking into your office, your clinic, right? And they have pain, most of them. And you're more, I mean, obviously, as we know, conservative treatment's always the first choice, but a lot of times the patients that need surgical intervention, I mean, walk me through, you're having to convince them, many of them, to do something that they don't want to do, that maybe they walked into that office and said, "You're not touching me," or something like that. Right. So I consider the process by which you you have to explain that to them. You're selling them on maybe that return to ski or whatever it is. Enough about my thoughts. Can you describe that process for us? Like,
No,
as a patient?
You hit on something. I mean, you do need to build a therapeutic relationship with your patients, and ultimately, the customer is not always right in the terms of medicine. They're not customers; they're patients, and they do have to rely on our advice. But kind of taking it through them with co-decision making, where we're both deciding on what the operation is. I will always give the patient more than one choice. And most of my patients are second opinions, so they've already heard it. They've already heard that they need a long segment fusion. They need this or they need that from another doc. And I'll say that's not wrong. That's not wrong. But why are you here to see me? Well, it's the real reason is I have back pain, but I really just have terrible leg pain. It's like, well, what if I helped your leg pain, but didn't do a lot for your back pain?
Right.
Would that be all right? And then all of a sudden we're talking about, in awake decompression or in awake microdiscectomy. And a lot of folks ask me like why I do it awake. The honest answer is I think, there's a lot of reasons. Obviously you avoid the risk of general anesthesia. You are able to examine the patient more professionalism in the OR, but it really is for me, trying to make the experience with as little hassle or burden as possible to the patient. Okay. So if they're going to get an injection, which we recommend, and we perform, our office performs injections. They're going to have to be NP after midnight or nothing to eat or drink. They're going to have to wear a hospital gown. They're going to have to get an IV, and they're going to have to, it's going to kill their day. If you're getting an injection, you're not doing anything else that day.
I didn't know that, honestly. Honest to God, I did not know that the injection carries the same NPO and all the other,
It does, because we have a kind of a local policy where we do all of our injections in the surgery center, which is like a hospital-like environment.
Yes, sir.
So I say, well, you had an injection for your leg pain, and maybe it worked a little bit, or maybe it didn't work at all, but you're sitting in front of me, and I think there's a surgical solution, but you're not going to have to go to sleep. You're not going to have a breathing tube. We get that hangover of a general anesthetic. It's going to kill your day. You're going to go home. You're going to sleep in your own bed, and you're going to be awake. And that takes a little bit of the fear away from it. That, oh, if it's so minimally invasive that you can do it awake, it must not be that bad,
Right.
So Jay you and I are getting to the age when we might need a colonoscopy, and it's going to be the same deal where it's going to kill your day. You're not going to have anything to eat or drink, for prior to the procedure, but you're not going to go to sleep during it, and you're going to get it. Nobody wants to have a colonoscopy or a root canal, but sometimes you need one, and I'm trying to make that a little bit of a less of a hassle for the patient, and that's one of the reasons we do do it in the surgery center.
Mm-hmm.
I found before 2019, before, COVID 2020, wait a minute, I don't have to be in the hospital for my
Right.
surgery. Is that okay? Is that,
Absolutely.
are you sure that's all right? But now patients are there's like, and you can do this outpatient in the surgery center. I don't want to be in the hospital. I read the paper. I know that there's cases soaring. Colorado's got a spike in COVID, unfortunately, despite our, early attempts at vaccination. And I was like, no, we're going to segregate you. We're going to keep you away from the sicker patients in the hospital. And we're going to do you in another place, it's going to be outpatient. And so that's really, I think really the awake thing has really taken off in the last couple of years,
amazing.
and it's been simulated, I think, by COVID, which is
Sure.
an unintended side effect of the, terrible pandemic we're going through.
100%. I mean, I talked about that on a few different channels about how COVID's essentially just spread up some trends that were already happening. It's sped up some trends that were already happening. And the shift to the ambulatory surgery space, or the ASC, as we know, it was already there because of the efficiency. It's a better experience. I've been a patient there. I had a minor surgery at an ambulatory surgery center, and it was wonderful. It was wonderful, not just for me, the patient, but for my wife and my mom, who were helping with logistics, with, the drop off, the pickup. They were getting regular updates via text messaging, because a surgery center understands that it's about what you said earlier, the patient experience. And if your practice is geared towards that, if I may, improving that patient experience, then the site of care is critical, because they understand it and they're partnering with you on that. So Awake, I know about it because I've lived in this industry, but for people that watch this that maybe don't understand the difference between, avoiding the general anesthesia and what you're doing, can you maybe talk a little bit more about that in layman's terms, just kind of versus just lay it out, because I think it's fascinating. I think it's the future. It's a big part of it, at least. It's not for everybody, but.
Well, I think a better term, I think Awake kind of gets a lot of the buzz. It gets the blood pressure up a little bit, but it's really regional anesthesia, if I'm being frank. It's not like we're doing it with no anesthetic. And I was influenced a lot from my partners who are, sports medicine, total joints, and they do all their surgeries Awake. And I kind of walked in the room of one of my partners, and he was doing, a total hip arthroplasty, a new, artificial hip joint. And, there's a large incision. There's large blood vessels, and the patient was awake. And I was like, wow, how can you do this? He's like, well, we do regional anesthesia. We do a block. They go home with an ambulatory infusion pump. So a little box that gives them pain medication when they leave. I was like, okay. And then they do, neuroaxis anesthesia, either an epidural or a spinal anesthetic. And I was like, okay. I was like, I wonder if I could do that for my spine patients. And I just happened to be, and working around the spine all the time. So I do a lot of my own blocks to kind of add to the efficiency, add to the consistency of the experience. So I do, my own blocks, whether they're epidural or spinal. We send them home with ambulatory infusion pumps, just kind of like a total hip, a total knee, a total shoulder. Those are all done Awake. And the reason we do them Awake is for a faster, earlier recovery. They don't get the same, and general anesthesia is safe. I don't want to say that, don't have general anesthesia, but it does have risk. And really, nobody really understands how a general anesthetic works, And so we give you this gas and it knocks you out. We know that it happens pretty consistently at a certain alveolar concentration. You'll get a certain level of anesthetic, but nobody exactly knows how it works. And it does put a lot of stress on the body. I've heard anesthesiologists, other surgeons say that, going to sleep with a general anesthetic, it's like having an elephant sit on your chest. It's like that much pressure on your heart, and it causes a technical term called diastolic hypotension, which is when the heart fills in diastole, there's lower blood pressure. So the heart is most at risk during, general anesthesia. And so it's essential for people with bad cardiac disease, but I think it's good practice and other people, even with healthier hearts, not to go through that process unless absolutely necessary. And I don't do all my surgeries, with regional anesthesia. My cervical work, my artificial disc in the cervical spine, I'll go under general anesthesia. My anterior work, for whether it's an O-lift or a type of fusion from the side,
Right.
or an A-lift, a type of fusion from the front, those are all general anesthetics. But T-lift, the posterior fusion, my workhorse operation is done awake. And so are my microdiscs, my laminectomies, my routine bread and butter surgeries are usually done awake. Even, spinal cord stimulators, if I'm doing, taking care of a patient with chronic pain, that's done awake too. And I feel
Absolutely.
like the time that you have with the patient, you learn a lot about them. You learn a lot. We talk about,
amazing.
Where they've been from, and where they're going, and what they want to do. After the surgery, I can examine them
Wow.
during the operation to make sure I've done a good job. Some
that's
patients prefer to be in twilight, more asleep. Go ahead.
Well, just wanted to start to interrupt you, but just thinking about
Yeah.
all my years in standing at the foot of the bed, in some of those cases where you really need to know if they you need to either check motors or just check their reflexes, and so you have to wait for the patient to come out of the general anesthesia so that you can do your tests, and because the spinal cord and the spine and
Right.
the lumbar plexus of nerves innervates in the legs, and so you need to feel their legs and their feet, right? And I just thought about, wow, if they're awake, you can say, hey, wiggle your toe for me or something like that.
Oh, I'll do that. Yeah.
That's unbelievable.
Do that all the time. All the time.
That's just unbelievable. I just thought about all the times that we sat there waiting. You can't touch the back table or anything. So let's dive into, because I want to be respectful for your time. You mentioned that getting to know your patients. And so let's take that in. How do you let your patients learn about you? And maybe I don't want to lead you towards social media, but I've certainly been a fan of you on social media in terms of how you market yourself, your practice, the type of pathologies that you're taking on with this novel technique. So really just kind of, how do you spread the word about you and your practice? What are you working on today?
Well, I mean, we still do. Well, actually, we're doing our first in-person community talk tomorrow, but
nice.
It's also going to be on Zoom, and all the talks we had in the past were, community only or online only, which is what we did during COVID.
Sure.
So getting out, to the community and kind of telling them, there are options for you or what your options are, I think is important. But I came from a very conservative, medical school on the East Coast, and I was told like no reputable doctor advertises. You just hang your shingle up and patients will come to you. And all you need to do is, get a business card. You probably can't see this card too.
There you go. You got to
get a business card and you're all set. But like your new business card, I think, is your website,
Absolutely.
And once the patient is booked an appointment, a lot of times either before the appointment, which is the typical time, they'll read your bio and read your kind of practice philosophy before the appointment. And they'll understand, what you do and what you don't do. But sometimes, I'll see a patient and they'll see me later and they'll say, thank you for your service. I didn't realize that you served in Afghanistan. I was like, oh, you didn't read my bio until after the surgery? He's like, no, I just thought you're. So I do think having like a website or having some type of presence on the internet, and you can decide how much you want to do or not, is important, especially in private practice.
Yes.
And the military is totally different. You can go to the military's website for the hospital I worked at. No mention of any of the surgeons that work there. Our pictures aren't there in the bio. And I get that in the military environment. There's operational security. We don't really need everybody in our adversaries to know who's doing what, where they live, and where they practice. And so they keep that kind of tight-lipped. And I was very hesitant to post anything on social media in the military because we have a lot of, rules and more rules that you have in the civilian world, and what you can talk about and what you did. I remember wanting to write a paper on some of the injury patterns, and I actually got that paper published, but it had to go through public affairs, operational security. And they're saying like, well, it's like, well, this is just an academic paper on, some of the things I took care of in Afghanistan. They're like, we don't want our adversaries knowing what works. I was like, I think I know what works, but I get it. So we had to, really sanitize it, in a way that protected the, national security. But now that I'm in private practice, I'm more feel to publish more. I'm more free to have a presence on social media, which, I value. And I think it's helpful. it's not for everybody, but I do think, having a website with a good bio and updated bio is kind of the minimum,
Yeah.
minimum you want to do.
Well, and I think people, I mean, look at today, in today's world, it's changing, just like we talked about some of the trends that were sped up in 2020, 2021. The way in which we buy things, the way in which we consume information and make purchasing decisions has drastically changed. I mean, think about people that are buying cars literally sight unseen on Carvana or other mediums, or you think about people purchasing houses with their realtor is doing a FaceTime walkthrough or some sort of like a video share because it's across the country. And, our neighbor, he works for DoorDash, exactly how they bought their house. They moved from the Bay Area and they live next door, and he's fantastic. And he let me drive his blue Vespa around for my Halloween costume. It was fantastic. So shout out to Varun. But
I bought this house sight unseen.
Did
I bought
you
my
really?
car. I ordered it in August. I saw pictures on the internet, and I made an offer, and I was like, well, it looks like a good place to live. And I bought my place. First time I saw it was when I moved in.
I mean, but that's what I'm talking about, Dr. Braxton. That's exactly it. You made a big decision. The biggest personal economic decision is buying a house, and then cars second. And I would say maybe surgery's the third, with a little bit more risk involved or a little bit more perceived risk. But what you're doing, and respectfully, what I'm trying to do, right, from an industry perspective, is build online trust. Build trust through video, through written, through letting your patients hear about you from you. And you've got a compelling story with your military background. Thank you for your service, with your focus and determination and commitment to making spine surgery better for your patients in Vail and surrounding areas. So they're going to want to hear from you. And I think it's fantastic that we have these mediums that we can, it's not advertisement, it's just connections and sharing your story because it's a compelling one. And if I'm getting spine surgery, I want to know who's operating on me. I want to understand that. And, I just think that it's the wave of the future, and it's already happening because I can see what you're doing.
Well, Jay, I do want to push back on one of the things. I think the biggest decision is not buying your house; it's who you marry. And I did meet my wife in person before I got married. But we did meet online.
So okay, yes, it's like 1 in 6 now, or 1 in 5 people meet online. I mean, so look, I'm glad you brought that up. Yes, and I don't know if my wife watches this, but if she does and she comes upon this, yes, baby, the biggest decision was you. But you're right. It's information. And if I'm making a big decision, or I'm doing research on behalf of a family member or a neighbor or a friend or anyone, and I've actually done this. I mean, I know I'm very connected, feel very blessed to be connected with a lot of surgeons, not just in the spine, but mostly in the spine. And I can help people depending on where they are. They'll come to me and they'll ask, just like surgeons will reach out to me and ask about, like, hey, I'm thinking of moving to this practice, or, the network of people that I can help I'm grateful for. And I use social media to look at the websites. As you said, that's your presence. Videos are really, really impactful. I think like the statistics are 80% higher. Or go ahead.
A lot of people don't think about, Jay, is that a lot of surgeons will sometimes change jobs, and I live on my reputation. And if I move, sure, the people I see at the grocery market and the ski slopes and at the hospital, they all know me. But if I move to another community, say 100 miles away or whatever, they don't know me.
How would they know you?
Except for my online presence, and your online reputation follows you everywhere. So
that's right.
Whether it's your presence on social media, or your website, or even reviews on Google, they may or may not be fair, but they're the patient's opinion that follows you everywhere. No matter where you go. And so I think it's helpful to cultivate that and take an active role in building an online presence.
That's right.
My practice manager will always ask patients to do online surveys, and they've done enough of them from the hospital and from our practice. But I was like, hey, if you want to, you had concerns about surgery and you went through the awake procedure, would you mind taking a few minutes and saying what you're good or bad, what your experience is, and Google, that's on there. You can't erase that. You can't edit it. It
No.
goes on there and it follows you, everywhere you go. So I think that's one thing to consider, especially if you're thinking about changing jobs, either for family reasons or personal reasons or economic reasons, you're thinking about changing jobs.
Yeah, exactly. I mean, goes for surgeons and for others, right? Going through a little bit of a career switch right now. And it's fortunate to have LinkedIn because contact information changes but it keeps you relevant with your connection, your network. So absolutely.
Well, I over the weekend talked to a spine rep, a person that works in the industry, and he was let go without cause. And the first thing they did, was took his computer and they wiped his entire computer, all of his contacts, wow. And they could do that. That's his computer is company property, and everything on that computer, whether it's business related or personal, gets wiped. And I do think, like you said, having a LinkedIn network as well and contacts and building up those relationships, those things will follow him to his next job. So that's an interesting thing. Offline, you were sharing that there were some changes that you're going through. Do you feel comfortable sharing what's going on with you, or because I want to know more about Jay, because we talked a little bit about what you're doing. I was really excited in Miami, and I'm excited to see you see it blossoming and developing.
Thank you. Nothing's fully baked, but I do know that there's something here. I know that there's opportunity to continue to provide, at least try to provide value to the industry and make an impact. That's all I ever really wanted to do, was just make an impact. And I was doing that for a while as a spine rep when we met, when you came to Austin, and making an impact in my own way in a small little piece of the geography. But, now the network has expanded. And again, back to LinkedIn or back to the social platforms that we have, your reach and your knowledge and your connection base can grow, exponentially. So I started this podcast because I just wanted to connect with others and share the stories that I feel so fortunate to get to hear from surgeons, from, industry colleagues and other visionaries. And it's been fantastic. I'm not making any money off of this. It's just a fun way to connect. But I think also what it's done is it's opened up some other potential opportunities. I'm not trying to dodge your question. It's just very much in flux, and it's there's a lot of moving parts. I just think that I'm blessed and grateful to be connected with people like you, because again, back to the thing I said at the top, I mean, none of us have an industry role unless there's surgeons that welcome us into their ORs. And, cases matter. I feel blessed to have been standing in those cases for a long, long time. So I can have not only an understanding for what you and your colleagues do, but what industry and kind of where our role is, in that equation, because I've been there. And I think that empathy helps me lead and connect with others. So regardless of what I'll do, I'll have that.
My biggest ally and supporter is usually from industry. It's the industry rep in the OR. And I've got such a good relationship, with my rep, that he could look at my hands and tell that I'm cross-threading something, which is putting in the screw and having the bolt not going quite right. There's a little bit of catch. He could just, as a cross-thread, we've got another set screw, to put you on. And sometimes when I'm being a spine surgeon or any kind of surgeon, is a little bit like being a chef. Okay.
In what way? I love this. I want to hear about it.
So you work hard to prepare this great thing, and you see the nerve, it's decompressed, instrumentation's perfect, and you try to appreciate it for a moment, and then you close. And nobody really gets to see that, nobody really understands that, or it's this kind of ephemeral moment where that you did a good job in the OR, and then you close it all up, and the patient hopefully does well. And like the patient doesn't see like the nerve. Well, in my case, sometimes they do. They'll be watching.
Sometimes they can watch,
but that moment, and sometimes the only person I have to share that moment with is my rep. Like they really feel that feeling of accomplishment, and I share that. And that's why I say, we hate infections, because it's like having a great meal at a restaurant and then getting like the stomach flu afterwards and getting
Right.
sick. Like, oh, it's such a good meal, but I got sick
so
from
good.
it. You did such a great surgery, but you got,
Right.
a complication from it. So I think of that. There's some parallels of being a chef and who's cooking like a fabulous meal that's just, is this fleeting moment. There's this moment where you see it and it's good. Okay, time to close. Let's close it all up. Let's get them, let's get them healing.
I'm just trying to understand what role we play in the chef scenario from an industry perspective. Are we the hostess?
Well, I think
are we the waiter?
No, they appreciate it. They know what's going on. I don't think that if I'm chef de cuisine, they're chef of the line. They know that
it's humbling.
It's come together.
That's awesome.
Most of my surgeries go well. Occasionally, sometimes I struggle, and I'm trying to find the right words. Like, can you give me that instrument with that hook? The one that I like to use in the situation.
And they got you.
And the nurse is looking at me like, English, please.
Yes.
You have a name for this instrument? No, but my rep has already run out of the room. Got it.
He's already getting it.
Here's your J hook. Here's what you need, because we've been through that.
I try to explain. It's hard. It's really difficult for people outside of the industry to understand kind of the dynamics of surgery and in particular why I need to be there. Right. When I was a sales rep or an intraoperative sales consultant is very different word than the Red Hat gang. But so it's difficult to explain, because the best way I've said is that if the surgeon is operating, which you're operating, you're scrubbed in, you can't break scrub, you're all over the nerve, and things change. The reason why I'm in the room is because I hopefully have the trust from that surgeon to help offer suggestions, plan B, C, D, E, F, whatever we have. And then the knowledge to when to go get that tray, right? I can't leave the room in certain situations, but there are some that I can, right? And just the situational awareness to just be a valuable service, spoke on the wheel for the team. I think it's just such a humbling opportunity to develop that trust. Yeah.
The service that I value the most is unpaid. It's unreimbursed. It's kind of being helpful, getting, the right implant or what you need at that time of surgery. But if, they attach the word sales to it, because that's of course how they reimburse it. But I tell my patients, there's going to be somebody in the room because they're awake. First of all, when the patient comes in the room, I make everybody introduce themselves.
Oh, that's great.
My name is Ernest Braxton. I'm a surgeon. I'm Mr. X. I'm a rep from, company X. I'm the anesthesiologist. I'm the nurse. I'm the PA. I'm the X-ray tech. Everybody introduces themselves and what they're going to do in their operation.
It's great.
And the way I explain it to my patient is, imagine you got this complex thing that you got from IKEA, and then having somebody from IKEA in the room explaining nuances and how to assemble and put this together.
But we can't.
Wouldn't that be a good idea?
Yeah. Yes.
It's like, they're going to explain to you how to, you reviewed the technique guide. You've done the case, and maybe you haven't done that case many times, or you don't do it that frequently. You have a person that day in, day out knows the inner diameter, the outer diameter. I will ask very esoteric questions during the case of what I'm doing, and they're just a reference library. Like whenever somebody hands you an implant, it always says the anterior height is 11 millimeters. What's the posterior height?
Right.
They'll say it's 8.5.
Sure.
Okay, so that's 6 degrees of lordosis. And so they're like a walking encyclopedia, a subject matter expert on the things that you're implanting to hopefully help patients get better. And so that's an invaluable service. And I know what it's like not to have a rep, because I spent 6 months in Afghanistan, and I couldn't get anybody from any industry to come to Afghanistan and help me put in instrumentation. So I did it all on my own. So I know what an extra burden it is on you, especially in a combat wartime environment, to like, okay. Well, we're out of 5.5 pedicle screws. So what are you going to do now? And so I sometimes had to improvise things in Afghanistan, but I was my own rep in Afghanistan. So that's how I know how to put everything together and take it apart, is because I did it for myself, and it's much better to have, a rep do it, but.
Well, we think so too. So what's something in your life that's truly inspired you? If you think back, just changing gears a little bit more to kind of you, what would you say? Is there something or someone that's truly inspired you?
Well, I mean, of course, I've had a lot of mentors in my life. I've had a lot of support from my family, but I think the thing that's, and I don't want to be cheesy and hokey, but
Mm,
it's just really true. We have this place in at my old hospital in San Antonio called the Center for the Intrepid, and you'd see like wounded warriors, you know, coming back with a missing limb, missing,
right.
and and making it and not bitter and just happy to
Yes.
serve, and
Yes.
it's that example that's kind of always motivating. Like if you think this is bad, you think traffic is bad,
Mm,
is this a inconvenience or is it a disaster? And
that's right.
traffic is usually an inconvenience, and
Hmm.
or you're in the supermarket line and the person in front of you, it's like the 10 items or less line and they have like 20 items. Do I need to lose my cool over this?
Right.
Is this an inconvenience or is it a disaster? And so that's the first thing. It gives you some perspective when you take care of these
Perspective.
folks, of like, what they're dealing with, what they're going through, and it also inspires me to, try to make things better. I think a new burgeoning field of neurosurgery is the brain machine interface, coming up with better implants, better devices, better technology to improve lives. Right now
Hmm.
we're kind of, it's in its infancy, it's
Yes.
getting better with robotics and enabling technology for a screw. But if you look, but like, what about an arm or a leg,
Mm.
or a
Hmm.
spine, I
Or a
mean,
spine.
these are things that, you know, um, generations of surgeons will be working on implanting and
I agree.
controlling. I was blown away seeing a person who was quadriplegic, control a flight simulator with their mind,
It's
bank
unbelievable.
left, bank right. It was crazy.
Yeah, it's really exciting when you think about it, Dr. Braxton. Technology is here and it's advanced and it's disrupted and transformed a lot of industries, but for ours, I don't feel like it has really scratched the surface.
No, no, it hasn't.
How do you
It's
see this? Or go ahead.
no, no, no. What are you going to say?
I was just going to say, just how do you see this? I mean, you mentioned kind of the, interface. Just how do you see this transpiring over the next like short period of time, 15 years, 10 to 15 years?
Uh-huh.
I mean, it's changed
Well,
drastically in the last five. So it's hard to
so
even.
well, Jay, what we're going to see is greater availability and access to care.
Okay.
Folks that normally wouldn't get surgery are going to be able to get high quality surgery in rural and remote parts of the country. I live in a very remote part of the country. It happens to be Vail, but the
Right.
population here is only about 30,000 people. We have harsh weather.
Mm-hmm.
And I mean, other than that, I can't complain. It's beautiful here. But I saw this thing that kind of blew my mind. It was a young man sitting at a grand piano and he had a virtual reality headset on. So
Okay.
he couldn't even see. He had like a virtual reality or augmented reality headset
Yes.
on.
Yeah.
And it
Yes. Yeah.
told him which keys to play.
Wow.
And the guy had no experience playing the piano, but it told him, it lit up a light on each key and gave him a rhythm to
Mm.
play the piano. And he was playing like, like a pro,
That's
like an
unbelievable.
expert.
That's unbelievable.
That is unbelievable. Instead of years and years in learning the piano, learning the notes. I mean, he really didn't. He wasn't even staring at notes. Like
Wow.
reading music. He
No,
was
it's
just
just
looking at a headset, saying, "This is how we do it." And I
amazing.
think to a certain extent, enabling technology is going to allow more surgeons the ability to do high quality work,
Mm.
um, and also spend more time developing newer and newer technologies. So if I can kind of back up a little bit,
Sure.
imagine prehistoric man. Okay. So you don't have a Whole Foods or a shopping mall.
Right.
You don't have a television. You don't have all these things that make your life easier. And you've got to wake up every day and put all your energy into getting food,
Mm-hmm.
hunting, gathering, what have you. And that leaves very little time for creativity, for science, for arts. And as you get more enabling technology, now you have division of labor, you have agriculture, you have all these newer things that come with civilization. You don't
Mm-hmm.
have to worry about your
No.
breakfast because that's already taken care of. You can spend more time um,
On other
creating the
things.
next masterpiece, inventing a cure to cancer, researching
Mm.
and studying. And I think as we can spend less time on the technical nuances
Mhm.
of playing the piano or putting in a pedicle screw. We now
Right.
have enabling technology. It's not like the time is going to be wasted. I think the
Right.
time is going to be spent on developing things I haven't even thought of.
That's beautiful. What a world, right? I mean, that's the opportunity
Yeah.
cost that you're talking about, because you're spending so much time now doing. And if you envision the piano keys, and there's a great analogy
Uh-huh.
into the pedicle screw, right? I would imagine
Right.
it takes
Right.
even more time to understand how to do the pedicle screw than it does to learn how to play a piano. But the analogy is sound. If you're using enabling technology or any type of augmented assistance,
Right.
for guidance or for precision measures or for accuracy, whatever, and you're able to then, in that same surgical moment, either maybe outside that OR time, maybe before and after, but do different things that are going to help that patient, or even, as you said, develop cures for other diseases. I mean, that's just, wow. It's exciting. You're talking about the technology is gonna open up things that we're not even thinking about, and that's what's
I don't think
amazing.
I don't know what the next breakthrough is going to be, but it's going to
Right.
be somebody who's able to spend more time and energy and effort on that.
Yes.
The Malcolm Blood about 10,000 hours, because
Mm,
now they have the time to do that. You know, I mean,
absolutely.
I mean, to do this podcast, it required a lot of enabling technology for us to be able to, you're in Texas, I'm in Colorado,
Right.
for us to communicate. And if you were just worried about putting food on the table and like hunting and gathering, you didn't have, I mean, it'd be impossible for us to really communicate and share these ideas.
And it
I hope
was,
something yeah.
no, go ahead.
No, I mean, so much comes out of just communicating, sharing
It
ideas,
does.
whether it's this conversation here that we're having, whether
Absolutely.
it's my orthopedic colleagues, like, how do you do the outpatient total hip surgery? Or, oh, okay, I bet I could do that in my practice.
That's right.
In borrowing and stealing ideas, they say that stealing one idea is plagiarism, stealing many ideas is research.
That's a great, I
I think
love that.
Churchill said that.
Who
Yeah.
said that?
Churchill.
Churchill. Yeah, you're
Uh,
right. That's
yeah, I'm
awesome.
paraphrasing. Yeah.
No. I know exactly what you're talking about. That's a great one. You know, I just think that it's such a gift, what we get to do. What we're able to do. What you're able to do. What industry is able to be a part of, right? And you mentioned, kind of having that trust in the room. What about your team? Let's kind of round out there with your surgical team. You mentioned your, assistant Lori, so maybe just kind of like when you're, because coming from the military, I don't want to. I've
Right.
not served, but I have good friends who have, and teamwork is everything. Teams are everything. And so,
Absolutely.
how have you built your team? What does that do for you today? Kind of where maybe just spend some time on the teamwork aspect of surgery, and kind of your
Right.
thoughts. It'd be great.
So, I have a pretty large team compared to the average spine surgeon, but I found it very essential to kind of run the practice that I'm proud of. But
Mm-hmm.
I have two physician assistants. They actually prefer to be called physician assistants, not physician associates. But
Right, right.
the label doesn't matter all that much. But they're really invaluable in working up, diagnosing, and helping me manage patients
Mm-hmm.
postoperatively. They interface with insurance companies, they interface with the hospital, and they
Yes.
interface with the patient when I can't personally call them. I do personally see all my patients, but my PA does a lot of work, and I have two of them.
Right.
Okay.
That's great. Good
Then
for
I
you.
have an office manager who also helps just run my day. So she
Mm-hmm.
runs my schedule, she runs my clinic. She's kind of the first face you see when you come in past the front desk, and she's not clinical, but she also helps me a lot with social media, arranging
Right.
time in my schedule to be on your
To be
podcast.
here. That's right.
Yeah, to be here. So,
Thank you,
and then I
Lori.
have, yeah, shout out to Lori.
Shout out,
And then
Lori.
I have my athletic trainer who's also super invaluable. So
That's awesome.
I kind of learned this from my orthopedic colleagues, but they use athletic trainers rather than MAs,
Mm-hmm.
and they kind of feel this role where they can assist in surgery, they can help open and close. They also are really good at gathering all the information I need to make a clinical decision. So if you're coming to me from Texas, maybe your MRI is there, or your
Right.
operative note is there, or this is that. They'll have all that information assembled for me to help me make my clinical decision. They also call all my patients as the first point of contact after my surgery. So between two PAs, an athletic trainer, and an office manager, that is a pretty large team. And then I'm in a larger team, which is my partnership, my group, that helps me with things that are important but not so pleasant, like billing and and coding. They help me with that. They help me with the electronic medical record that we have when we have difficulties with that. They also provide the infrastructure and support. They supply the MRI technicians and the MRIs, and they also help manage the physical therapists that we run. So we have this entire ecosystem that is really almost totally self-contained, aside from the operating room, which is in the surgery center or the hospital.
Right.
So and having these teams kind of work well, it was a little bit of trial and error. We've had, to help people in our team find other opportunities when they weren't a good fit. And it's hard to know that in an interview. And so I think a clinical, a trial is really the best way. It's like, you seem qualified. Let's hire you, for 6 months to see how you fit in. And then at 6 months, we'll make a decision whether or not you're going to stay in the team.
It's great. I think that anyone that, would jump at the chance for those 6 months to prove themselves. And I think it's a great way to do that, to build out your team. That's great. It's fantastic. Well, so I want to be respectful for your time. Do you have time for one more or a couple more questions?
Yeah, absolutely.
Okay. So let's talk about your, this is kind of a canned question, but I always like it because it could lead to other ones. What do you want your legacy to be? It's a deep one, but I'd love to hear your answer.
Yeah. So I've been thinking a little bit about that. I think by most average standards, I'm, a successful surgeon. I have, good patient reported outcomes. We make a nice living. We live in a beautiful place, but as I, get older, I do think about like, what is my contribution going to be? And so that's why I've taken up more of an interest. We actually formed through some very generous patients and a research foundation to help kind of advance the science, and having a large team allows me to do things like clinical research. And I've often talked to my partners, I think that, the group that I'm with, was founded many years before I joined the group, and many of the original founders have gone off to retire. I think, we should, do things to memorialize their contribution, like have a portrait of them in the office, commission portrait, and I do think that I do want to leave my mark in spine surgery in a tiny town in Vail, Colorado, but I do want to make a contribution to the rest of the state, the rest of the country, maybe internationally, and what we could do in research and invest in the science. And I do think that's why I've kind of been more willing to, because doing research is difficult. We are currently involved in an international clinical trial for spine fusion. We're also looking into partnering with another company to do a clinical trial on artificial disc. And it takes some courage and bravery and some trust in my part to do things that are literally experimental to advance things.
Right.
And so I do feel that is just being an island onto your own is not enough for me. I do want to interact more. It's hard in private practice. Relationships with industry have been the easiest way for me to kind of get out to meetings and talk to other folks. But I do want to be not just a custodian of the knowledge that was passed on to me. I think that's important to do that, but also to develop it and to see how far we can push it.
It's awesome.
That's humbly what I want to do. And also I try to make a contribution to outside of work with the U.S. ski team and with local charities, and try to give back and make that an important part of what we do with philanthropy.
Well, from my perspective, and I've seen a lot of things that you're doing, with advancement of techniques and for industry and whatnot, and you're doing a fantastic job of helping us, improve spine surgery collectively. And I definitely did want to ask about you being that, consultant for the U.S. ski team, and what has that been like? I mean, what a cool opportunity. Just incredible.
Well, that's something that um, I don't think I would have access to had I not been living in Vail, Colorado.
Right.
Had I not had partners who were already on, the one of my partners is the lead physician for the women's U.S. ski team. So a lot of my close colleagues are for the U.S. snowboarding team, and being able to participate in that, it does require, it's all volunteer. And
Right.
I do like to travel with these young professionals, which really inspire me. That talk about inspiring me. So we went to Norway.
Wow.
To work with the ski jumpers, and just to be there and to have a friendly American face in a foreign country. God forbid if they get hurt, to kind of render them care and get them where they need to be. And when somebody's ski jumping, it may not be a head injury, it may not be a spine injury, but just to be able to be that ambassador with the medical community of where they're traveling, where they're working. That was really the hardest part about COVID is that I was not able to travel with them over the last. First of all, the season in 2020, it's starting in March. It kind of came to an end, and it's been kind of difficult to travel internationally with them. I do hope as the pandemic gets under more control that I'm going to be able to resume travel with the U.S. ski team. But that's just a nice thing to kind of be there and support. I mean, I served in the military. I also feel very patriotic as I'm serving and supporting the U.S. ski and snowboarding team.
Yeah. Absolutely. I mean, that's just incredible. I mean, you literally you've got their back. It's a dad joke. Dad joke alert.
I like that.
that. I mean, so look, I always want to give my guests on the show, which I'm so grateful for us to spend this time, but I wanted to give you the opportunity to, if patients in Vail or surrounding areas wanted to find you, or, anything you wanted to, share here with the audience, whoever it ends up being. I'm sure tons of your colleagues hopefully will be watching, and I know a lot of industry folks, but where would you direct them if they want to find more information about you, or kind of some of the stuff you're working on in your practice?
Well, we talked about online. I'm available online. If you search Braxton MD, our website will come up. Before we really developed the telehealth part of our practice, and now it's kind of well dialed in. It was really cost prohibitive to get a second opinion or to come out and see us. But we do specialize in really, minimally invasive, spine surgery. A lot of my patients have had opinions elsewhere, and they choose to have surgery here, which I'm honored that they would come and see us. And they prefer to convalesce kind of away from, maybe where they live and work, but in a place like Vail, which is a great place to convalesce and recover from surgery. Absolutely. So if any folks are interested in a second opinion out there, I can't help everybody, but I can definitely give you an opinion, or maybe point you in my network of surgeons around the country, that are like-minded. I can certainly help with that. It's braxtonmd.com or vsortho.com. I think both of those show up pretty early in Google in online searches. Or if you're old-fashioned and you just want to call us, you can give my office manager, Lori. She's kind of our ambassador. She does a lot of office managing, but she can help with travel and hotel or whatever questions you might have. Her number is 970-477-7407. And I want to thank Lori for helping me get on this program and on this podcast.
Lori, thank you. You were great to work with as well, coordinating and just logistics of all that. Dr. Braxton's a busy individual, and evidently so was I last week. So it was good to connect and schedule this, because this is such valuable time. I'm grateful, Dr. Braxton, for the discussion. It's just so fun to understand your background, kind of what you're doing now, and then where you see the future going. All exciting, all great stuff. I just can't thank you enough for spending some time with me this evening. So thank you.
Oh, hey, thanks so much for having me on. I really appreciate it. We should do it again. You should come out in person, and I can take you on the slopes.
Now you're talking. I'll bring my wife. She's an incredible snowboarder. I'm still kind of a blue-green skier. I didn't grow up skiing. I was playing soccer the whole time. But my wife's incredible. So we'll come out. We'll do that for sure. And
all right, I'm going to hold you to that.
no, I'll be there. I'm going to end this recording. We're going to talk logistics about when. Thank you guys so much and gals for joining the Sultans of Sales podcast with Dr. Ernest Braxton from Vail, Colorado. Tune in next week.